All right. Welcome everyone to a special and very important conversation about one of the biggest threats to the effective delivery of mental and physical health care, namely the rising tide of loneliness and social isolation. My name is Boaz Gaon. I'm the CEO and founder of Wisdo Health, a social health and clinical referral platform. We are recording this webinar and we will be sending it out to everyone who are on this call. We will have time at the end of the session for questions, so please feel free to submit them in the Q&A or chat boxes so we can make sure that they are addressed. A very special welcome to our speakers today. Tom Insel, who really needs no special introductions, was as one of the leading voices in mental health care in America, spent 13 years as the director of the National Institute of Mental Health, and is the author of the brilliant book Healing, recently co-founded Vanna Health. And lastly, Professor Dan Russell is the co-developer of the UCLA 3 Loneliness Scale, which has become the standard for measuring loneliness and its impact on health and financial costs. We are convened today to ask, how can loneliness be solved at scale? In light of the rising and harmful costs of loneliness, as evident in the following figures, 30% of Americans 65 plus and 60% of Americans 18 to 65 are impacted by loneliness. That's 124 million Americans, growing an estimated 5% every year, and documented harmful implications on physical and mental health, with disastrous financial costs estimated at $161 billion for Medicare Advantage populations and commercial populations alone. These are obviously staggering numbers, emphasizing the urgency around what the current U.S. Surgeon General has called preventing a social recession before it is too late. So in light of the size of the problem, it's time to ask, how can we cure loneliness at scale for all Americans with long-lasting solutions? Tom, let's start with you. In your book Healing, which I recommend that everyone get hold of and read, you argue that lack of engagement with mental health services accelerated by loneliness is one of the biggest challenges facing mental health today. Why do you think that? And how do you see community-driven solutions preventing this problem from becoming even bigger?
Well, thanks, Boaz. It's a real pleasure to be part of this conversation. It's one that we don't have enough. I think, scientifically, we recognize that the need for social connection is every much biologically as important as food and water, and really it's a fundamental drive. It's a way in which our brains are architected, and yet it's not a topic that we talk about nearly enough. The issue of engagement is related to this because while we have done an awful lot over the last 30 or 40 years to improve care, it's interesting that you don't see the improvements at the population level. You don't see the outcomes really changing. If you look in the US, especially at numbers around suicide, around function, around a whole range of outcomes, functional outcomes that we would care about, in both morbidity and mortality for people with mental illness, the numbers have not gone in the right direction. We've done worse, not better, since the turn of the century. And the enigma about that is that when you talk to providers who are working really hard, they'll tell you that they're really helping the people they see. And I'm sure they are. The problem is that they're not helping the people they don't see. And as this slide suggests, it's something like 40% of the people who should and could be in care and would benefit are not in care. The study that was done by the National Comorbidity Survey, the NCSR, the replication back now 15, 18 years ago, did a really careful search on this, and they discovered not only that 40% of people were not in treatment, but of those who sought treatment, only about 40% got what they considered minimally adequate treatment. And of course, for those, not everybody got well, but about a third got the full benefit. I call this the 40-40-33 rule, because if you start to look at these numbers, what you begin to realize is that our providers probably are feeling some satisfaction in helping the people they see, but they're dealing with 6 or 7% of the population in need. And so the reason we're not seeing the population-based impact, the public health impact on morbidity and mortality, is because most people are not receiving the care that would and should help. And I think that's really a challenge. Of course, very quickly it begs the question of why, and some of it we often attribute to stigma or we attribute it to lack of access. Those are issues, and they're probably worth our considering. I think there are three other things that are probably just as critical, maybe more so. One is that a lot of people don't buy what we sell. They don't like the kind of care that is provided. There's a general distrust in many populations of mental health as we provided mental health care. But the third and the most overlooked and the most important issue around this lack of engagement is the illnesses themselves get in the way. If you're depressed, you're hopeless. What's the point? If you're anxious, you're avoidant, so you're not going to seek treatment. And honestly, if you're psychotic, you don't think you're sick. So why would you be going for care? So this engagement piece is tough, and it's really important for us to put this up front as one of the challenges we want to think about, and to remember it's more than just providing access. We have to figure out how to engage people who are not in care.
Thanks, Tom. I will have a question on that when we're done. Dan, let's move to you. There's been a lot of talk on this call about measurement, a lot of talk on this call about how to move the needle in terms of loneliness. Is the pathway referring people to clinical solutions? Is the pathway community, or is it a combination of both? My question to you, we were very excited, the Wisdo team, when we found out that there's a standardized measurement for loneliness, which makes it much easier to baseline members and then see how they perform over time. So my question to you is, how and why was the UCLA scale developed way back in the 60s and 70s? And even more importantly, how has your work since led into developing the 4 provisions of social health, none of which, and this may be counterintuitive, involve clinical therapy? Dan, are you? I don't think that you're on mute.
That's my fault. The UCLA scale was first developed back when I was in graduate school, which was a long, long time ago. and the whole idea was to try to stimulate research on loneliness. And one thing we learned quickly was asking people directly, how often you feel lonely, given the stigma associated with loneliness, was problematic. And so we developed a scale that was based on how lonely people describe the experience. And that's where the items came from. The short 3-item version that Wisdo is employing was developed by John Cacioppo and his colleagues as part of and used in the Health and Retirement Survey in around, I think it was 2002. But that short version of the scale has been adopted by a number of researchers in Europe and in other countries, but also in hospitals here in the States that I've heard of, and is being used really as a screening tool for loneliness. And again, I feel that's an appropriate use in that, the scale is going to detect people who are pretty high in their level of loneliness. And if that's your goal, that's fine. Now, the one thing here where it says, where we are going is from large national surveys in recent years. What I've seen is very high rates of loneliness among young adults. And that includes here at Iowa State University. So it includes college students, but also non-college students of that age group, the highest levels I've ever seen. And so many people believe, that the highest levels of loneliness are among older adults. Well, that's not true, and that has never been true. That the highest levels are typically seen in college-age students and high school students, but the rates now are very high. And I think an important issue is, why is that true? And is that a population that we should focus on? Now, in terms of the provisions of social support, Robert Weiss in the early 70s, in talking about social and emotional loneliness, linked them, the two types of loneliness, to these social provisions. And it turns out that these provisions he was talking about, these things we get from relationships with others, also correspond to what subsequently was termed social support. And what we have certainly found is that it's the lack of these different types of social support that is most strongly related to loneliness in our research. So these appear to be important aspects of our relationships with others. And that in terms of a focus on what you're getting from your relationships with others, this seems to be where one should focus on. And Wisdo, with its programs, is clearly trying through its peer support programs to provide support to the individuals you're serving. And that's one thing that really struck me when I learned about your program, is that it really looks to me like you are focusing on these different aspects of support we get from others. And if this is where I would want to focus my efforts in terms of improving the individual's relationships with others. And, one thing that's always been true about loneliness is that, some people are lonely despite having lots of friends and lots of relationships with others. So it's the quality and contents of those relationships that are important. Loneliness is not synonymous with social isolation. That's very clear. And so again, that, this is what I would take from what we have done and what I see Wisdo doing here, and it looks like it's working.
Thanks, Dan, and it is, and it's incredibly satisfying. We also need to be thankful to you, who pointed us to some of these provisions, who we really focused on as we try to amplify them in the digital experience. I do have one follow-up question to you before we move on to some questions from the team and from the audience. There's a really interesting description in your research about the differences between guidance and the 4 provisions of social health. And we've seen this many times in Wisdo, where if someone comes in and the first thing that they encounter is someone saying, well, here's what you need to do, often the result is that person taking a step back and not being interested in anything that you put in front of them, even if it's something that they can benefit from. While if someone comes in and you are able to say, I see you, I hear you, I care, which is emotional support, or communicate a sense of worth, which is, wow, that's amazing that you went through this, take a moment to be proud of yourself, increase a sense of belonging, and give a sense that you're joining a community that really cares about you and will be happy to see you return. And also, fourthly, the understanding that you can help others, which you call reliable alliance. If you are able to do that, then at some point, that person will be willing to take a look at a recommendation, for example, to take a look at therapy, to take a look at a care management opportunity, etc. So that distinction between guidance and interventions that are more geared towards reducing social isolation and loneliness, if you can talk a little bit about the differences between those two, I think that would be really interesting.
It's certainly true. One example of the importance of reassurance of worth, one thing we found early on is that reassurance of worth is associated with building the person's sense of efficacy. And so, giving them advice is one thing, but building their confidence and their ability to do what they need to do is perhaps the place to start. Mm-hmm. And we found that particularly in brief work that I've done in job-related stress, that reassurance of worth is critical. So yeah, simply telling someone, this is what I think you need to do, may not be successful in getting them to try what you're suggesting, even if that's the right thing to do.
Great. Um, so I do want to move to some questions that we have from the team and from the audience. It's always a pleasure to talk to you, and we always feel that every time we talk, that you help us close that learning curve between where we are and where we want to be able to solve this very big problem. And I'm sure there are additional people on the call who feel the same. So a few questions from me and the team, and then a few questions from the audience. Tom, you said something that was really interesting to me, which is that, yes, loneliness is a very big problem which affects hundreds, more than 100 million people. But when loneliness is coupled with a serious mental illness, then that combination can become very harmful and possibly even dangerous. So you've written about the comorbidity situation between loneliness and severe mental illness. Can you share a little bit about what you've seen in your work about what happens when someone with a severe case of depression or a severe case of bipolar is also afflicted by loneliness and social isolation?
Thanks, Boaz. The first point I'd make about that is it's not really a question that's asked that often. As I say somewhere in the book, probably the most overlooked issue in serious mental illness is social connection. And it's unfortunately not in the center of our focus when we evaluate where people are and what they need. I write a lot about what I call the 3 Ps for recovery: people, place, and purpose. And I think all 3 of them have some ability to leverage a social connection in a way that helps people to recover. We need to really, to begin getting past a sort of simple medical model to talk about a recovery model means that we start to ask for people with serious mental illness, how do they get the social support they need? How do they get the environment they need? And how do they get that sense of purpose? How do they, I thought Dan's point in the last slide was really important. One of the most therapeutic interventions isn't just getting people help, it's empowering them to be able to give help to others, to use their own experience to serve others. We find this over and over again, that one of the real springboards for recovery is when people get to that point where they can feel effective, they can feel that they're useful to someone else, that they have that sense of purpose. They can understand a mission. As Viktor Frankl said years ago, he or she who has a why can live with almost any how. And giving people the why, giving them that mission really does matter. So for me, I think it's really important to lock those 3 Ps together. And most of all, to say, hey, this isn't just a model. This ought to be what we consider as part of healthcare. It's really interesting to me that in a country like the United States that's spending now almost $4 trillion on healthcare, the organizations that are really focused on social support, like clubhouses that do this in many, many communities, they're often nonprofits that live on bake sales and maybe galas if they can get people together to give them some money. So we haven't yet gotten to the point where we understand that what we're talking about in this conversation needs to be integral, not just to health, but to healthcare. And the reason I am so passionate about this is that in the United States, the care you get depends on what's paid for. So if we're not paying for clubhouses, if we're not paying for social support, if we're not paying for the tools that help people to connect, and you can't write a prescription for social support that gets a reimbursement from either public or private insurance, it's not going to happen. We have to think about, in terms of how to get to scale, we have to think about how do we take what we're talking about here and make it integral to not just health, but to healthcare.
Thanks, Tom. I couldn't agree more. And one of the, I think, satisfying things that we saw, how helping others indeed does improve people's health. we were able to come up with a training program where people really learn how to become more helpful to other people. And it was incredibly satisfying and interesting to see how reductions in loneliness, increase in quality of life, and eventually even reductions in medical costs were even bigger and more massive if we were able to increase that person's sense of worth by helping them understand that they can help other people. So yes, we've seen that in the data, and I think that is one of the clues that this pilot has given us in terms of can we solve loneliness at scale.
Boaz, can I jump in for a moment? Because I think
Please,
this is really an
please.
important issue, and that is, what is the ROI for any of this? Because you have to make the business case if this is ever going to get done. I'm in a company called Vanna Health that's very focused not on sort of the Medicaid or Medicare population, but the Medicaid population, the most expensive and often the sickest patients. Many of our patients are costing the system already $50, $70, $90,000 a year. So it's interesting because these are the most expensive patients and we get the worst outcomes. So, when you're an entrepreneur, you look at that, that's a perfect storm. You're always looking for the place where we spend a huge amount of money and we don't get much in the way of results. When you look closely at that population, it's the need to create community, the need to be able to provide social support, and well, it's really the whole 3 Ps. And what we're finding is as we do that, while you are spending more on the kind of behavioral health part of their care, that's a tiny fraction of the overall cost of care. The total cost of care is driven by their pulmonary disease or cardiovascular disease or diabetes, all of which are way out of control, and all of which are relatively easy to manage with upstream care, with more preventative, more rational care. The problem is the way we do it now is it's one crisis to another, emergency room, inpatient, ICU, emergency room, the most expensive, most intensive way to give care. So I think when you start to look at total cost of care and you do what you're talking about with these programs that Humana is involved with, I'm quite certain that you're going to see an enormous savings. The VA has done this. We've seen it in the UK. We've seen it in Germany. We've seen it in almost any of the groups that have undertaken this kind of an approach. You can't just narrowly look at the behavioral health costs, which are going to go up. But if you look at the other 90%, 94% of your costs, they're going to come down 20, 30%. So it does make sense in terms of an ROI to get on top of this.
Yeah, and what we saw, and we're a few weeks away from publishing this, but the one area where we saw tying into cost reduction is hospitalizations, where people are just healthier, the risk of them deteriorating becomes lower. And one thing that was fascinating was to see that when we were able to create a sense of trust with those members, when suddenly there was a rise in their loneliness score or their unhealthy days score, A, we immediately saw that, and B, when we asked them why that happened, they told us. So that is an opportunity to step forward, say, hey, would you be interested in taking a look at a resource that can help you move towards health rather than deteriorate into illness? So that is the time that we were able to find, and again, we'll be very excited to share those results, but they are really interesting and very, very powerful. Dan, I do have one question that is popping up in the Q&A, and also something that we've encountered, which is the connection to COVID. And more specifically, loneliness has shot up, and you see roughly a 5% annual increase in loneliness since in the past decade. And I think all of us will align on the answer, but let me just ask it: will loneliness end with COVID, or are you seeing in the data that this problem is just going to get bigger and bigger unless we do something about it?
Well, recently I just saw a review that was published in the American Psychologist based on longitudinal studies of loneliness. And again, this is not great in that they weren't all using the same measure, and they weren't all the same, intervals and so forth. But it showed a small to moderate increase in loneliness over that period of time. And this was across a variety of populations, a variety of, meaning in terms of countries, studied in a variety of age groups. And so I think an interesting question is, okay, what's going to happen post-COVID? Are we going to see a decrease in loneliness of a comparable amount, with lockdowns ending and so forth? That's an interesting question, and that's just as interesting as the COVID increase in loneliness. And I hope that people are going to do those studies and are situating themselves to do those studies. But as I say, the other thing that concerned me in these large national surveys I mentioned earlier, they all happened before COVID. And we were seeing very high levels of loneliness in the young adult population. So what I'm concerned about is, as these individuals age, are we going to see even higher levels of loneliness, than we've seen in the baby boomers like me, as we age. And, so that's what really concerns me. And, it may be that COVID will turn out to be about a 2-year blip where loneliness went up and then comes back down, but we don't know that yet. Or will there be a continuing increase? People talked about the loneliness epidemic before COVID showed up and the increases. And again, so it was starting already at that time. And I don't know that, I certainly don't think that COVID going away is going to lead to a reversal of that trend, meaning I'm assuming we'll see continued increases in loneliness. And, as I walk around this campus of 30,000 students and see all these students on their phones communicating constantly with their friends, supposedly, well, it ain't doing them much good, is what it looks like to me. So we really need to understand that.
Thanks, Dan. We're seeing that too. And I think one statistic that you shared about the young adult population in Iowa that you looked at showing higher loneliness rates that you've ever seen is maybe a clue into how this is not a problem that is going to go away soon. Tom, a slightly provocative question to you is, should loneliness be defined as a condition? And whether that would enable regulation, CMS, other bodies to reimburse, at least for severe cases of loneliness, which will really kind of fuel the trend that we've seen in the past 5 to 10 years of trying to address loneliness as a condition.
I haven't really thought much about that, so I'll just give you my first reaction, which is there may be a downside as well as an obvious upside. So yeah, you define it and you start to measure it, you start to know about it. I worry, though, that if it ends up being its own box. And what strikes me about this issue is it's so cross-cutting. It's so important across so many different areas of not just healthcare, but of health, and then more broadly, who we are as a society. I think Dan's comment is really what I've been thinking about so much lately, is that for this next generation, how is this going to play out? Digital natives who seem to only be able to connect through a screen and yet aren't creating the kind of intimacy and authentic relationships that are necessary to overcome that sense of loneliness. Like, how do we fix that? Where do we go? I think that's a really fundamental question. I think, if you end up trying to put it into the DSM 6 or 7, whatever the next one is, I'm not sure it's actually going to be a sign of progress. It may be better for us to study it in the way that we're talking about it now, which is as a broad social issue that needs attention from lots of different perspectives.
Great, thanks, Tom. So we have 48 additional comments in the chat, which I won't go into right now, but I think that's another sign of how this is a topic of conversation that quite a few people are trying to take a look at seriously. So apologies for not being able to address all the questions. We will do that in follow-up emails that we will send to people who attended this webinar. I do want to thank the participants again for a fascinating and crucial conversation. This conversation is the first in a series of webinars, thought leadership webinars that Wisdo Health wants to bring about in the next few weeks into this big and important question: can loneliness be cured at scale? We will be hosting the next one on October 26th. Those of you who want to make a note, between 1 p.m. to 2 p.m. Eastern, focusing on the cost of loneliness with Annette Fellows, Vice President, Health Services and Products at Healthcare Transformation at United Health Group, and Dr. Cheryl Ye, Chief Medical Officer at AARP. Both have done really interesting work about the cost of loneliness for the seniors population, and they'll talk about that study in our October 26th webinar. We view these important webinars as also an opportunity for community building. Wisdo is a community effort, so we practice what we preach. So the innovators on this call, the researchers and practitioners, we view this as an opportunity to really kind of join hands to see what we can do together to solve this very big problem, because we believe that this mission of solving loneliness at scale can be achieved if we work together. Thank you everyone for joining. Look out for that follow-up email, and have a great rest of your day.